So welcome to session 14. My name is Manuela Schmieding. I'm a medical oncologist from the University of Vienna, and together with my co-chair, Michael Stehler, we're going to chair the session on practice-changing papers. Our first speaker is Scott Shepard, and he's going to talk about pancreatic lesion population of Leitzbach 004.
Thank you very much for the kind introduction. Thank you for the invitation to speak today. It's a great pleasure to share this important data with you. We've heard some extremely powerful and moving testimony from patients with VHL this weekend about this important data. And although this is a kidney cancer meeting, we're going to see these patients in our clinic, and it's important that we're familiar with these response data in extrarenal lesions in patients with VHL disease. So the objective is really to understand the efficacy of belzutifan in treating pancreatic manifestations of von Hippel-Lindau and discuss the evolving role of HIF-2 alpha inhibition in shifting the management of VHL from surgical to systemic therapy. Of course, VHL disease, this audience will be familiar that this is a multi-system tumor predisposition syndrome. It's caused by pathogenic germline variants in the VHL gene. And patients are at risk to develop benign and malignant tumors across multiple tissue contexts, including clear cell kidney tumors in the kidney, pheochromocytoma and paraganglioma, and CNS hemangioblastomas. Pancreatic lesions are common in patients with VHL, and about 70% of individuals have some manifestation, including benign pancreatic cysts or serous cystadenomas, which are benign, but they can also develop pancreatic neuroendocrine tumors, which are classically non-functional, although they can metastasize. And crucially, there are no approved systemic therapies for patients with metastatic pancreatic neuroendocrine tumors. And of course, the underlying molecular biology of VHL is that tumors typically develop when the remaining wild-type copy of VHL gene is lost. This leads to an accumulation of HIF-alpha within the cell, whereupon it translocates to the nucleus, dimerizes with HIF-beta, and this compound has transcriptional activity and transcriptionally activates hundreds of genes involved in cellular metabolism, invasion, survival, proliferation, neoangiogenesis. And that led to the development of potent selective inhibitors inhibiting the dimerization of HIF-alpha with HIF-beta, and so compounds such as belzutifan entered clinical development for treatment of this disease. So LIGHTSPARK-4 was a single-arm, non-randomized phase 2 clinical trial recruiting patients with genetically confirmed VHL, and they needed to have measurable renal tumors to enter this study. Although patients with extrarenal manifestations were also allowed, they recruited 61 patients. All patients received 120 milligrams orally of belzutifan until disease progression. The primary endpoint was overall response in VHL disease-associated RCCs, with secondary endpoints including overall response in pancreatic and other VHL disease-associated neoplasms. And patients had tumor assessments at baseline and then every 12 weeks thereafter for a minimum of 3 years. So the study met its primary outcome. This data was published in 2021, led by Eric Yernash and Ram Srinivasan, showing, you can see here that in the waterfall plot, that nearly all patients had some shrinkage of their renal tumors, overall response rate of 49%. And this was the preliminary report following 22 months median of follow-up. They also noted meaningful activity across other VHL-associated lesions, and these data led to regulatory approval for the management of non-metastatic VHL-related neoplasms in the US and now, of course, in Europe and the UK as well. And it established belzutifan as a new standard of care. But questions really remained about more detail about these responses in extrarenal lesions, but also the durability of these responses. And for the focus of the presentation today will be this paper describing the pancreatic lesion responses with a median of 38 months of clinical follow-up. So actually, all 61 patients had at least one pancreatic lesion, which was defined as either a serous cyst adenoma or a pancreatic neuroendocrine tumor, and 22 of these 61 patients had a measurable pancreatic neuroendocrine tumor. As I said, it was over 3 years of median follow-up for these patients, with 62% of patients continuing belzutifan treatment at the time of this evaluation. And you can see here there's this really striking clinical activity in all of the pancreatic lesions, with 84% of patients reaching a partial response or better, and 17% of patients having a complete response of their pancreatic lesions. And then in the pancreatic tumors, pancreatic neuroendocrine tumors, of the 22 patients, 91% of patients achieving a response, with a third of patients achieving complete response in the pancreas. So, this treatment is highly active in these clinically localized pancreatic lesions. The responses seem to be durable. So the median time to response was 8.3 months, but again, with this median of over 3 months of follow-up, you can see that the median duration of response was not reached, and in fact, 100% of the responders remained in response at the time of this analysis. So I think what we can see is that there is some differential sensitivity across these different tissue types. So the one caveat is that the length of follow-up for each of these reports is slightly different, but you can see that complete and partial responses in the pancreas seem to outcompete those within the kidney and the CNS tumors. So it's hinting at there being some different underlying biological consequences of VHL loss in these tumors and sensitivity to inhibiting HIF2 alpha-related transcription in these tumors. So take-home messages: belzutifan provides an effective, non-surgical treatment option for VHL-associated pancreatic lesions. And belzutifan is really shifting the paradigm for VHL from reactive surgical management to proactive systemic disease control. And of course, this is hugely important for patients who previously would be undergoing highly morbid surgical intervention for these pancreatic neuroendocrine tumors. Thank you.
Thank you, Dr. Shepard. Please join us at the podium, and I would now like to invite Guillermo de Velasco to discuss this paper.
So belzutifan in bone hyperindividual disease, a shift away from preventive surgery. So I'm going to discuss the data from the LIGHTSPARK-005 results in pancreatic lesions. So what was the standard of care before belzutifan? So traditional management of VHL-associated pancreatic lesions, basically we had surveillance, minor plus preventive surgery, especially for those bigger lesions. But at the end of the day, it's multiple surgeries through your life, and we didn't have any approved systemic therapy, although we had some data with tyrosine kinase inhibitor, use of label, modest efficacy, about 27% of response rate. So the question really is, what does belzutifan offer for these patients? So if you look at the key data, it's basically response rate, pancreatic lesions, 84%, really amazing data. Overall response rate in pancreatic neuroendocrine tumors, 91 with 7 complete responses. All this data is quite amazing. 0 patients require pancreatic surgery after treatment began. So this is amazing, and usually is well tolerated, mostly grade 1, 2 adverse events. So then, what are the questions? What this paper doesn't tell us, and I think is the only some questions that we need to think. So first of all, a single arm. So it's not randomized design. So we know how many of those patients could be on surveillance for a period of time because we don't have a control group. It's any clinical trial, it's a very selected population. So all patients were ECOG 0 and 1, no large renal tumors, real-world applicability may be a little unclear for some patients. The short-term surrogate endpoints, overall response rate and growth rate reductions are promising, but we don't have that data in long-term survival for these patients, especially because some of them could be very young patients. And there is the unknown treatment duration. So one of the important questions, should belzutifan be continued indefinitely for those patients? For how long? What happens when it's stopped? What happened for those patients? So there are questions that we don't know. And also, delay safety signals. 30 months is really good start. But lifelong treatment in young patients, so I have some patients in the clinic that are 25 years old, that have been for 5 years now on belzutifan. So the question is, how long should I maintain this treatment for my patients? Chronic anemia, hypoxia adaptation, fertility, development impact. So we don't know for these questions for patients that will may be receiving this treatment forever. And the other question is, surgery is completely avoided or is just delayed? So at least by the time being, it's really good data, but we need to think, and obviously we have lack of biomarker stratifications. Not all VHL's lesions behave the same, and who really benefit most, and whether we could do for those patients specific treatments. So the take-home message is belzutifan replaces repeated surgeries with daily oral therapy, really good, robust, durable control in both PNETs and adenomas, reduce the need for interventions, and reflects of success of biology-driven treatment in hereditary cancer syndromes. I think it's really a landmark study. I think more evidence is needed, especially for clinical practice management, and definitely I think this study shows that personalized medicine is no longer a promise, it's a responsibility for all of us. Thank you so much.
Thank you, Guillermo. We would now like to invite Dr. Koen van der Min to discuss neoadjuvant toripalimab plus axitinib for clear cell RCC patients with vena cava thrombus, the NeoTex phase 2 study.
Thanks everyone for sticking around to hear about the NeoTex study. I've not been involved in the study, but I am involved in the analysis of the NeoAVAX study, analyzing axitinib with avelumab in this neoadjuvant setting. Learning objectives to demonstrate the clinical efficacy of this combination of toripalimab and axitinib in patients with clear cell RCC and inferior vena cava thrombus, and to highlight potential biomarkers of clinical efficacy. So this has been shown by Dr. Libovic yesterday already, but patients with inferior vena cava thrombus can be divided in 4 different categories, ranging from level 1 to level 4, with the tumor thrombi extending all the way up to the heart in level 4. In this study, they investigated a combination of agents that has been investigated in the Reno-TORCH study, a randomized phase 3 clinical trial conducted in China. And in this clinical trial, the efficacy was established, and an overall response rate was shown of 57%. Then in the NeoTex study, patients with clear cell RCC and a tumor thrombus were eligible for inclusion. All the patients needed to have a minimum of a CT3B tumor, either with positive lymph nodes, and also patients with metastatic disease were eligible. All the patients had a good performance status and good organ functions. And these patients were treated with a combination of toripalimab, which is an anti-PD-1 agent, once every 3 weeks, combined with axitinib in a schedule that we all use. And these patients were treated for a total of 3 months, or 12 weeks. And then surgery was conducted to remove the primary tumor as well as the tumor thrombus. The primary endpoint of the study was the downstaging rate of the inferior vena cava thrombus. Secondary endpoints were tumor thrombus length, objective response rate according to RECIST, safety, progression-free survival, and a preliminary biomarker analysis. So this is then the patient population. In total, 29 patients were enrolled, and 25 patients were eventually treated. All patients, so none of the patients was lost to follow-up. In total, 4 patients eventually did not undergo surgery, so a total of 21 patients underwent the surgery. But all the 25 patients were evaluable for the primary endpoint. I think important that indeed 5 patients had metastatic disease, as can be shown here on the right. And the majority of patients had advanced tumor thrombi. So 7 had stage 3 and 9 had stage 4, so really extensive disease. So this is then the most important outcome. On the left-hand side, you can see the initial tumor thrombus level. So 9 had stage 4, 7 had stage 3, and 9 had stage 2. And overall, in 44%, there was significant downstaging of the inferior vena cava thrombi, with, for example, one patient initially having stage 4, and after the treatment had a level 1 tumor thrombi. So really a significant reduction in the tumor thrombus. On the right-hand side, you can see the median length of the tumor thrombus with a reduction of a median 2.3 centimeters. The objective response rate was 40%, so RECIST partial response in all cases, so 10 out of 25. Then here you can see the perioperative outcomes, still clearly indicating that this is major surgery with a median duration of almost 5 hours, 314 minutes. 50% of the patients was admitted at the ICU after surgery. I think another important outcome is that the median progression-free survival was longer than 2 years. 89% of the patients had a 1-year progression-free survival rate. So that is clearly indicating that this is an active treatment regimen, I guess. So then one slide about the biomarker analysis. So the researchers performed a multiplex immunofluorescence analysis of the pre-treatment tumor biopsies in 13 patients. And on the left-hand side, you can see the most important results, showing that there was a rather heterogeneous tumor immune cell infiltrate. And then most striking, if you compare the patients with a RECIST response, so partial response versus the non-response, that particularly the patients that were having a response had low TIL infiltrates in this analysis, but this was only in a small subset of the patients. So take-home messages. Neoadjuvant toripalimab and axitinib reduces the inferior vena cava thrombi from clear cell renal cell carcinoma in 44% of the patients. And TIL levels, as well as potentially characteristics, may serve as a biomarker of treatment efficacy. Thank you.
Thank you, Dr. van der Min. I'd like now to invite Axel Becks to discuss this paper.
Yeah, thank you very much. I prepared a couple of slides. I think what is important to realize that in this patient population that was just presented, and these are very contemporary data from the United States, from a high surgical volume clinic here from Able. 90-day mortality and major complication rate in patients with level 3 to 4 thrombi at 10% and 34% respectively. So 1 out of 10 patients dies from this intervention. It is known from multiple retrospective case series that drugs are active, especially in the area of TKI. We had a couple of series that were presented. There were also some caveats because some of these patients progressed eventually. But with the exception of only one phase 2 trial of neoadjuvant axitinib, the downsizing has never been investigated prospectively. This is the Naxiva trial that Grant Stewart led. These are the slides that were originally presented at GU ASCO in 2021. So basically the trial included 20 patients and the period of pre-treatment was a little bit shorter. It was 8 weeks with axitinib. Primary endpoint was also reduction of the thrombus, but most importantly, the secondary endpoint that's for us important as clinicians is that it led to changes in the surgical approach into less morbid surgical approaches. So you have to think in terms of turning an open procedure into a laparoscopic one, or for example, more importantly, avoiding cardiopulmonary bypass in 41.4% of the patients. Now here's a slide where I compare both studies. We always discuss that cross-trial comparison. Neotax is a little bit bigger, 25 patients, but it's still a considerable small trial. They used a PD-1 inhibitor plus axitinib. That is interesting because we hadn't had these data yet. And they pre-treated for 12 weeks, which is about the limit that most neoadjuvant trials would use. I think most importantly is they try to focus on the higher level of thrombi, so starting with level 2 and 4 thrombi only. And they could demonstrate that the change of surgical approach was 61.9%. And if I just look at this, and this is my personal opinion and a summary, I would say that it leads to clinically meaningful tumor thrombus downsizing in level 2 to 4 thrombi. It's a small trial. And the way the data are being presented, you had avoidance, you could see that on one of the slides that Kuhn was presenting, is of cardiopulmonary bypass sternotomy was 23.8%. So there was 5 patients of 25. There was less extensive liver mobilization in 42%, and the approach was changed, as already mentioned. But I think that given that 9% had a level 4 thrombus, and this would be the patient population where you do atrial surgery or a cardiopulmonary bypass, I think that the impact in this group was probably even higher than the 23.8%. It's actually surprising that the authors didn't mention that. And yeah, what to make out of that? The biomarker work doesn't impress me. I think what they end up with is basically that if you have low TIL, you probably also have a better prognosis. That's one of those associations. I would like to see much more data on that, because what you eventually would like to have is a discriminatory biomarker. Could be an easy one, could be an imaging one that shows you that you're on the right track of tumor downsizing. However, what I consider encouraging is that in the waterfall plot you saw that none of these tumors fulfilled the criteria of progression. Does that mean it's safe? In 25 patients, I think no, but it is certainly encouraging to investigate that further in a patient group of level 3 to 4 thrombi. That would really give me the safety to build these trials now. As we discussed them yesterday, I think this is an area where we would like to see a paradigm shift, also because these patients are at risk of further tumor progression. So I think this is the main outcome for me from this study, that it would encourage me to really build a trial in patients with higher level thrombi and then investigate it in a larger patient set. Thank you very much.
We now would like to invite Sophie Wilkenhoff to give the presentation on the Sunny Forecast trial that we all really are looking forward to.
Thank you for the introduction, and I'd like to thank the organizing committee for the invitation to present the publication on the Sunny Forecast trial. So the Sunny Forecast trial was recently published in the Annals of Oncology and is a prospective randomized phase 2 trial of combination immunotherapy with ipilimumab and nivolumab versus standard of care in non-clear cell renal cell cancer. So this is the study design. So untreated metastatic or locally advanced non-clear cell renal cell cancer patients were randomized in a 1-to-1 ratio to Arm A, which was combination immunotherapy with nivolumab and ipilimumab, followed by nivolumab maintenance therapy, or standard of care, which was in this trial investigator's choice. Stratification factors were histology, so papillary versus non-papillary, and IMDC risk score. Central pathology review was mandatory in this study. The primary endpoint was the overall survival rate at 12 months, and secondary endpoints were overall survival rate at 6 and 18 months, progression-free survival, objective response rate, safety, and quality of life. This was a one-stage randomized non-blinded phase 2 trial designed to provide a power of 80% to show superiority of ipi/nivo over standard of care at a significance level of alpha 5%. Out of 372 screened patients, finally 309 patients were randomized and 157 allocated to the ipilimumab-nivolumab arm and 152 to the standard of care arm. The standard of care in this study was mainly TKI monotherapy and mainly sunitinib. 78% received sunitinib, 7% cabozantinib, and around 10% received TKI plus immune check inhibition. These are the patient characteristics, which were balanced between both treatment arms, and on average, 75% of patients had an intermediate and poor IMDC risk, and on average, half of the patients had had prior nephrectomy. When we look at the histological subtypes, we see that 56% had a papillary renal cell cancer, and 44% of patients had a non-papillary renal cell cancer. There were different entities, but the most common were chromophobe and sarcomatoid and rhabdoid. The sarcomatoid was defined as more than 20% of sarcomatoid features in the lesions. This was the primary endpoint, so overall survival rate at 12 months, which was significantly better in the combination immunotherapy arm with 78% compared to 68%. And at the right, you see the Kaplan-Meier curve. The median overall survival was also improved in the combination immunotherapy arm, but not statistically significant. The exploratory analysis of the PD-L1 status showed that in patients with a PD-L1 CPS score of 1 or above, the combination immunotherapy showed a significant increased overall survival compared to standard of care. When we look at the response rate, this was also increased in the combination immunotherapy with 33% compared to 20% for the standard of care. And the largest difference was seen in the non-papillary subgroup, where 38% for the combination immunotherapy compared to 17% for the standard of care. And when we look into more detail for the major subgroups, so for the chromophobe, there was a response rate of 27% for the combination immunotherapy compared to 10% for the standard of care. And for the sarcomatoid subgroup, although small numbers, there was a high response rate of 70% for the combination immunotherapy compared to 25% for the standard of care. The progression-free survival was not different between both treatment arms and was on average 5.5 months. The subsequent therapies, so the same proportion of patients received second-line treatment, so on average 65% in both treatment arms. And the most commonly used second line after combination immunotherapy was cabozantinib in 32% of patients. And the most commonly used second line after standard of care was nivolumab in 26% of patients, but also cabozantinib use was seen in 24% of patients. And in total, 30% from the standard of care group received nivolumab in a subsequent line of therapy. When we look at the adverse events, there were no new adverse events observed in this study, and there was on average 60% of grade 3 to 4 side effects in both treatment arms, and treatment discontinuation due to toxicity was observed in 17% for the combination immunotherapy and 9% for the standard of care. So the authors conclude that this is the first prospective randomized trial comparing combination immunotherapy with standard of care in non-clear cell renal cell cancer. Ipilimumab nivolumab had a significant better overall survival rate at 12 months compared to the standard of care arm, and the primary endpoint was met. Exploratory analysis showed a significant overall survival advantage associated with a PD-L1 CPS score of 1 or higher. Thank you.
Thank you very much. We now want to invite Tian Zhang from UT Southwestern to discuss these findings.
Thank you. So I think I may have misunderstood the assignment because my colleagues have all had slides and I do not. But I'm happy to place the Sunny Forecast trial for us in context of the non-clear cell kidney cancer data that we currently have. It's been more than 10, 12 years now since Dr. Tenier and our colleagues around the kidney cancer field did the ESPN and ASPEN trials. And if you'll remember, I'm sorry I don't have the curves to show you, but if you'll remember, median overall survival on those trials was somewhere around 15 to 16 months. And so we have come quite a long ways with Sunny Forecast. This is a well-controlled, randomized phase 2 trial of ipilimumab, nivolumab compared against standard of care treatments. Most of these patients received on the standard of care single agent TKI, so the sunitinib was the predominant treatment. So I think the ESPN and ASPEN trials give us a good historical context. And what they set up early on was very good in terms of thinking about the 65% one-year overall survival improving to about 80%, and they achieved that endpoint with that median overall survival of 33 months. So we've come a long way. We've doubled that survival across non-clear cell kidney cancer cohorts. I think unanswered questions are if these 78% one-year overall survival rate means also that 1 in 4 patients died of their disease, presumably within that first year. And so could we do more for those 1 in 4 patients who did succumb to their cancer during that first year? What else? Could we continue to push the needle for these variant histologies? And then if we take a look at non-clear cell kidney cancer, our pathologists have really pushed the envelope in defining molecular definitions in the newly rolled out WHO classification of kidney cancers. And so now can we start thinking about disease-specific biology and targeted therapies for these molecularly driven tumors instead of bucketing them across. And then finally, we have another IOTKI trial that Dr. Albiges just discussed an hour ago across the hall, B61, lenvatinib with pembrolizumab. That also showed compelling objective responses across these non-clear cell kidney cancer cohorts. However, it was a single-arm trial that did not have a comparison cohort, but quite compelling, and it would be interesting to think about what that comparison might be if we looked at ipilimumab, nivolumab versus lenvatinib, pembrolizumab. I don't know if that trial will ever be done. And then finally, I do think we should continue to enroll to trials that specifically enroll patients with these variant histologies. PAPMET-2 is an ongoing trial of cabozantinib alone compared to cabozantinib atezolizumab. Maybe they decide to add a third cohort of CTLA-4 with PD-1. That would be an interesting addition to make the trial more contemporary as the standard of care changes. And with that, I'll conclude my comments. Thanks very much.
Thank you, Tan. Fascinating that you don't really need PowerPoint slides. Are there any questions from the audience? I hope it's going to be a question and not a comment.
No, I just wanted to say that the Sunny Forecast is an important trial because it's randomized. But really, I think the primary endpoint, choosing 12-month OS probability is totally inappropriate. And it does not, the interpretation and the conclusion to say that nivo-ipi was superior to sunitinib, because at 1 year, OS probability was 78 versus 68, because it doesn't differentiate what happens after 12 months. I mean, you know, a patient, it's not just 12 months and you stop living. I mean, those patients will live 13 months versus 31 months. You're not making a difference between 13 versus 31. So I think this is, unfortunately, I think a very good effort to have a randomized trial, but really, I don't think it's conclusive at all. This is inconclusive trial because they used the wrong, inappropriate primary endpoint of a probability at 12 months or a milestone.
They did present, as are the median survival for the ipi-nivo treated patients. It was about 33 months. And so I do think that in that very well-designed trial, it is showing superiority. The hazard ratio was right around 0.81. So even though they did a 1-year cutoff, it continued to have survival benefit across the follow-up.
Lisa?
Lisa Pickering, Marsden, London, also for Sophie and Tian. Do you have any thoughts around the activity we saw in the chromophobe variant histology in Sunny Forecast, which I think was quite striking and surprising to me, where I have been accustomed to understanding that chromophobe is relatively resistant to immune checkpoint inhibition, but we saw quite marked activity in the Sunny Forecast trial. Do you have any thoughts you'd like to share with us all about that? Thank you.
Well, I think it's it's true that it's striking that it's such a high response rate in the combination immunotherapy. Yesterday, there was the hypothesis that perhaps there were some more sarcomatoid features in those patients. I don't know whether the cutoff of the 20% to define the sarcomoid subtype, that would make an explanation that perhaps there were chromophobe patients with less than 20% sarcomatoid features. That's just my thought, but I don't know.
Sure, and I think, we have treated a good number of chromophobe histologies across the CANI trial, for example, cabozantinib, ipilimumab, nivolumab, an investigator-led trial based out of Dana-Farber. And the general activity was quite low in even a triplet trial. And so that trial has stopped chromophobe enrollment. So I do find it surprising. Maybe there's some component of the CTLA-4 inhibition that was the difference in this particular in study forecast, but it's interesting, and I think if we're potentially posing options for patients with chromophobe histology, it should be mentioned as one of the options.
More questions? I have a question for Dr. Scheber. So what do you think makes these pancreatic lesions in VHL-DC so specifically responsive to HIF inhibition?
Yeah, I think that's a fascinating question. I suppose to slightly ask that in reverse, we know that as kidney tumors progress, they do gain additional copy number and mutational events. And I think our sense is that this probably reduces reliance on the hypoxic signaling within these tumors. So there's a potential sort of escape route there for these tumors whereby they might become less sensitive. But I think that a lot of these differences will be shaped from the different cell of origin. So these are likely to have different epigenetic programming and different sort of baseline transcriptional activity. We know that leaves an imprint on these different tumors, and I think that there must be some particular sensitivity to HIF2 alpha inhibition in these. But of course, what we kind of need to do as a community, and it's definitely going to need to be collaborative effort, is to start collecting the rare samples where these patients progress and have surgery, and it offers an opportunity to get a lens on those progressing tumors. But there will also be relevance, of course, for the sporadic kidney cancer field, where these are also open questions. Yeah.
Picking up on that, do you think, although those patients have multiple lesions, which are not to be mistaken as metastatic disease, that avoidance of surgery would be an endpoint that we should look into? Maybe both of you can comment on that.
Well, I mean, I think it's really important endpoint for these patients, especially when, at least when you see just not in pancreatic lesions, in all these patients that they've been already having, because they didn't have any other options, they've been with surgery after surgery for different reasons. So this is like a total game changer. Like they stop having interventions. And I think obviously it's a new endpoint, but definitely in my experience, at least with my patients that I have, definitely it's like a key important endpoint for them.
Yeah, I totally agree. And there's a huge physical and psychological morbidity associated with repeated surgical interventions. So anything that can reduce that, preserve end organ function, is clearly a huge win for these patients who previously had very limited therapeutic options.
I have a question for Dr. van der Min. So is PD-1 inhibition plus axitinib your standard procedure to downsize cava thrombi, or would you consider any IO-TKI combination?
Yeah, I think it might be good if Axel answers this question, because I typically do not do the surgery, but for the localized tumors in our country, once there is resectable disease, officially these agents are not approved. But nonetheless, I think this study really clearly shows that there's activity and that you can reduce the tumor thrombi and reduce the complexity of the surgery. So it might be good that there will be follow-up studies looking into this combination.
So what I know is that there's, I think from Vitaly Margulis in the UT Southwestern in Texas. They're doing a study with pembrolizumab and lenvatinib. Looking at the response rates in metastatic setting, pembro-lenva would be very interesting. That's what I thought until I saw some data at ASCO of a trial. It was a 17-patient trial that was presented, I think as a poster, not even as an oral, of pembro-lenva for just in the non-tumor thrombi setting. And there the response rate was actually lower than what we saw in neo-ABACS. Now, having said that, I mean, in all these small trials, I think we shouldn't make too much out of it. For me, it's more a proof of concept, proof of principle, and I think lenvatinib, axitinib. But axitinib has also been shown in the Naxiva study, but also in a single-arm trial from the MD Anderson on primary tumors to be very good in downsizing. So that would be, at least for a trial, a medication to use. I wouldn't use that outside trials. But what we are doing, just to interrupt you, is when patients are metastatic, currently we have in London, for example, a IVC thrombi MDT. When we think there's a patient with a level 4 and peripheral metastasis, we really prefer to put them on systemic therapy, not only out of that principle that we now should give systemic therapy first, but the surgical risk is so high in them that you're grateful you have an option to put them on systemic therapy within the approval.
I think that concludes this session. Thank you to this panel. And I would invite the next panel to the wonderful wood fire up here. There are going to be 2 arsonists and a couple of firemen, and you have to have the name of Tom mainly to be part of this. There are only 2 outliers. It's Anu and me. So please, Lisa Pickering, Tom Waddle, Tom Mitchell, and Tom Powell. Could you present yourself up here? Thank you. Alles Gute, guten Flug.